Alright, guys, so now we're on to the review. So, first things first, what I basically ended up doing was similar to what I did for MFM. Dr. Weaver's she's reliant when it comes to red text for the most part. However, it does help to know kind of the context behind some of the red text. That's why it's kind of dangerous to use like only red text. I did that one time it wasn't Weaver, but it was Dr. Babos, and that kind of came back to bite me because she also does like red text. Um, so that's just a heads up. Sometimes it's worth reading the stuff around it to like fully understand the red text. So that's something to keep in mind. So that's why some of the stuff I have on here is not red text slides, but it's stuff that will help you understand the red text a little bit better. Or maybe it was like good examples that I thought I would just keep in there. Maybe explain a couple of them. But yeah, so that's kind of how I did that. Usual system, stars are like the more important things, especially if there's more than one star. Typically, those are the ones I remember either being really important or being maybe an exam question or something like that, something super important. So typically, those are the ones that have stars on it. All right, so this one, so just to, because if you have just the red text, you wouldn't understand kind of like how it gets to phase one. But basically, what this whole chapter is about is kind of like talking about the different phases and like how prescription opioids and things like that are prescribed. So the first phase you have is like the preclinical phase, and this is where you'll hear a lot more about like lab type stuff. So you'll hear more about, they're testing it with rats or doing in vitro studies, other types of studies before they take this particular drug that they're testing into humans. So this is what this preclinical phase is. That's just something for context, not super important. Let me move this stuff a little bit more out of the way. It's kind of crowding some stuff. All right. So phase one. So the things that are important on this slide are in red. And I do have, the star here. She did ask, I think, a question pertaining to maybe what's in one of these phases. Um, I think it was kind of asking you. It was like a first order type question. I remember. It's kind of like which phase is this describing? Something like that. I think that's kind of what this question was. But anyway, so phase one, notice that it's only healthy human volunteers. You don't have anybody that actually has the disease or the condition that this drug is trying to target. It's only healthy people. And the reason that you do phase one, like what's the point behind it, is that you're trying to understand the drug's pharmacokinetics and pharmacodynamics. So that's the whole point of phase one. So make sure you know the point of phase one and that it's healthy individuals. All right, phase two, these are going to be people that these are going to be only people that have the condition. So it's like the opposite of phase one, right? And so what it's used for, phase two, it's used for the preliminary assessment of efficacy. And what that means is just to basically see how well the drug actually works. So that's kind of like your first test of that. And that makes sense, right? Because these are the people that actually have that condition. So that's what phase two is. And then phase three, I have 2 stars on this slide only because phase three is important and also labeling is kind of important as well. I think there may have been a question on labeling specifically, but I can't remember right offhand. But anyway, so phase three, you notice it's like a little different, and this is the part where you do labeling, right? And that's where it gets approved is at phase three. And what labeling basically is, it's like what has to be inserted, like what the insert is for that drug, is kind of what the labeling is. So like when you open up, or you have like a bottle of like aspirin or something like that, right? It's like the instructions that are on there and like what can go wrong and stuff like that. That's what the label basically is. Um, actually, the label's usually like a really long thing, but you don't really see that unless you like when you get a Z pack. It's like a super huge document that like nobody reads. Maybe if you're a pharmacist or something. But anyway, the point of phase three is efficacy, safety, and benefit risk relationship. So that's what you're trying to understand in phase three. Yeah. Then, so product labeling, something that I thought was really important, and maybe that's the question it was asking about labeling. Was this I have bold and underlined here? But that it must be approved by the FDA, and that ANDA must be filed for approval of change. And what ANDA is this thing back here, the abbreviated new drug application. That has to be filed for approval by the FDA, basically. So that's how you get your label made, and that's how like phase. And this is all happening, by the way, within phase 3. And this is the kind of stuff that you'd find on that box warning or the label. So it's quite a bit of information. It's pretty much everything you would need to know about that particular drug. All right, so now on to the last phase here. So phase 4. This is going to be your what they call post-marketing surveillance. And basically, what population's being done in this is actually a large, diverse population versus kind of like smaller groups. What phase 1 and phase 2 were. This is kind of out to the public at this point. Phase 4. And then allows for identification of idiosyncratic and rare side effects. What idiosyncratic means is basically like allergic reactions. We'll cover that a little bit later. And of course, rare side effects as well. So that's kind of the point of phase 4 is to kind of weed out any kind of thing you might have missed with the label. But like I said, this is kind of like actually released to the public at this point. All right, so now on to legal classification of drugs. The thing that this slide I found really important was asking about the schedule stuff. So notice that C2 thing down there, or Schedule 2. That was important to know, just because it's like important for the state. At least, definitely for the state, but also a lot of different states as well. But yeah, so that was the thing I found was really important on this slide. But of course, anything in red is worth knowing. But anyway, so non-legend or over-the-counter. So this is like basically any kind of drug that's not like a normal type drug. So it's like over-the-counter, like aspirin or something, right? That will be valid for over a year. So you don't have to worry about it. If it's been made and written, then you don't have to worry about getting a new one. You can just hold on to it for about a year, right? Then legend drugs. So this is going to be like different from the non-legend, right? This is going to be valid for a year from the date written, unless it's controlled by the DEA due to risk of abuse. So those legend drugs, that'd be more like maybe a sartan or losartan or something like that. Something that's like actually like a pharmaceutical drug, right? That you typically think of for like disease control and not over the counter. So that would be your legend drugs. And those are also valid for a year, like I just said, unless it's for a controlled substance of some sort. And so that's where we get into Schedule 2. So Schedule 2 specifically is what's in red here. Now, they all differ based upon like refills and if it can be prescribed or whatnot. That's what these different schedules are. But Schedule 2, Schedule 2 prescriptions must be written. They cannot be refilled whatsoever. Okay, and you can write multiple prescriptions, but you date with the correct date and write "do not fill before." So all of those facts you do have to know, just in case you would ask about any of those. Because I think it was like a question about like maybe it was telling you what drug it is. So it was telling you like it was like obvious like controlled substance. And it's kind of like, well, what thing should you do with this kind of medication or something like that? It was once again kind of more of a first order type question. We'll move on. Okay, so side effect versus allergy. So an allergy, that's just of course an adaptive immune response to an antigen. That's all an allergy is. Totally makes sense after you guys have had immuno and everything. You kind of covered all that. I'm sure you know it pretty well by now. A side effect, however, it's like related to the drug's actual activity. So it's not that your body's responding to it. It's more so that the drug kind of can be maybe too toxic or be in an individual that's kind of more at risk for something. That's more of what a side effect is associated with, more so than an allergy, right? And of course, that's going to be more dose related and predictable. What is a prescription? So it's just a legal document written as part of a proper prescriber-patient relationship. I only include it because it's in red. I include every slide that's in red, but some of them are just kind of a given. All right, now on to prescriptions required in Tennessee. I put a star on this one because I think she might have asked something related to this. Not entirely sure what she asked from this. I know she didn't ask the bottom part that was in bold because I was like, oh, okay, it's in bold. It's got to be important. No, it's not important. Um, but just know all of the things in red here. So patient name, date written, things like that. Just know all the red. Every prescription requires those things in Tennessee, anyway. All right, now on to pharmacokinetics. So now I included this slide just because I thought the notes section kind of like it has my thoughts in there. So I don't know if it'll help you at all, but anyway, so the difference between pharmacodynamics and pharmacokinetics. Pharmacodynamics is kind of like how the drug actually works, so it's like the pathway that it goes down, like what its actual effects are, versus like pharmacokinetics. So that's what pharmacodynamics is. It's just the study of that, by the way. And then pharmacokinetics is more the study of like how it moves throughout the body. So it's kind of like whether it's where it's eliminated, how it's distributed, things like that. And it's summed up pretty well in this chart anyway. But I thought it was a good slide. How do we get drugs into the body? Once again, nothing red here. Just thought it was a nice reminder of what these different little letters mean. If some of you guys haven't been around medicine much, like I wasn't at the time, never really heard much of this stuff, so it helped out quite a bit to have these little abbreviations. Because she just kind of like from here on out, she doesn't really tell you what it is. She just kind of puts IM or PR or whatever. So it's just something to kind of know for later on and now. Integral. So this is going to be stuff that's happening via the GI tract. So notice it has like SL, buccal, PR, so it has a little fact about that in red, and also it has your oral or PO or per oral, and that's going to be your most common that's going to be going throughout the GI tract. So the differences between the two are what's highlighted in red here. So SL, buccal, or PR, so per rectum, those drugs they bypass the GI environment and they bypass the first pass, which happens in the liver typically. So basically, it's just something, and with that in mind, it doesn't have to go through those kind of like longer taking processes. So therefore, it's like fairly rapid onset. Of course, it's not going to be anywhere near as rapid onset as like IV. Right? IV is about the fastest you can go. There's no way you can go any faster than that because it's going directly into your bloodstream, right? So it's pretty fast just because it can bypass this stuff. And then oral, however, that one's more of a lower takes longer to go through everything because it actually goes through your GI tract and gets absorbed, in your intestine, and then has to go and enter hepatic portal circulation once it's absorbed. Because that's typically, what your food stuff does, right? When it gets absorbed, is it will go directly to the liver for, toxicity screening, basically. Um, and so, with that in mind, oral, of course, takes a lot longer, um, and it's a lot less toxicity tends to be just because um, that process takes longer and it's not like as much of a dose at one time. Now we got periental routes. I'm sorry if if I start pronouncing drugs wrong. I tend to have that problem. So just gonna let you know ahead of time. For the longest time ever, I was saying instead of metoprolol, I was saying metoprolol. So that's something to to look back on. So that's just a heads up. Some of these drugs I probably won't pronounce the best when we get into them, but of course we're not really close to that yet. All right, so all parental routes. So that, of course, these actually bypass the gut. So once again, it's going to be kind of a faster route, right? Because it's bypassing gut. Don't have to worry about any kind of dealing with acid or anything like that. And of course, and it can increase availability of poorly absorbed drugs. So that's something else to consider with using these routes. Parental route, I don't know. Trying. Once the drug is in, it can't readily be washed out. Okay, so that's something else to keep in mind about these routes. And then the one that you're going to typically be talking about with this route is IV. And like I've said, it's very, very rapid onset because it goes directly into the bloodstream, right? Doesn't have to do any of that other nonsense. It goes directly into it. And it's 100% bioavailability. That's something that's kind of important to know. So that's why I bolded it and underlined it, because that's like directly there. So of course there is kind of a risk for toxicity, but of course they're controlled for that because it's an IV drug. All right. Then you have the other routes with that, subcutaneous ID and IM, and they have an absorptive phase. The absorptive phase relays the onset of these, especially like when you think about subcutaneous, that totally makes sense. Or IM, it has to go through the skin and it has to, do these other steps that IV doesn't have to do. And so therefore that absorptive phase takes just a little longer. It doesn't take it near as long as um, doesn't take near as long as doing, like oral, of course, because it doesn't have to go through GI and then it have to go through the liver or anything like that. It just has to go through the skin and goes through the tissue. But with that in mind, of course, if it has any irritants at all, then of course it can cause tissue damage going through the skin. Makes total sense, right? On to the next. All right. Ionization. So this is very important. There's a table that kind of sums this up, I feel like, a little bit better. Not in red, but it is a nice table. I thought it summed everything up really good. So I have that later on. I don't know if it's 2 or 3 slides later or 15 slides later, but it's somewhere in here. But anyway, so acid drugs, okay, they'll be unionized in the acidic medium. Okay, and notice the thing that's also important to note here is that happens when the pKa of the drug is higher than the pH of like the serum or the medium. Okay, so that's where you have no ionization. And when things are unionized, they can pass right through like a membrane. So that's you want unionization if you want to pass through a membrane, basically. And then alkaline or basic drugs, of course, it's the opposite. It's going to be unionized and alkaline environment. So the pH is higher than the pKa of that drug. Um, and so with that in mind, if you had an acidic drug in acidic conditions, so say like, gastric acid, right? Say it's in like something like that, it's going to be easily absorbed because it's not ionized in that condition. However, if you had an acidic drug in a basic condition, um, like maybe for instance, like the GI tract or something like that, right? Like further down, then of course it's going to be ionized at that point. That acidic drug would be, and therefore it would not be able to be absorbed as quickly. Um, so that's basically what this whole thing is talking about. I get that it may be a little confusing sometimes. So of course, if you have any questions about that, let me know. But yeah, that's the main gist behind it. Um, and then of course, kind of just to build up on that, so that ionized form of that drug is basically stuck in that medium. So say for instance that acidic drug we were talking about that was in that basic solution, since it's ionized, it's not able to be absorbed anywhere because in order to be absorbed, it has to have basically no charge, in which we'll talk even more about that later. But yeah, that's the whole concept here. And the thing is too, she has this practice question later on that's like built upon kind of understanding if there's like a 3-layer system and they all have different pHs, like where will the drug end up based upon that concept. So it's important to definitely get this down. Um, and I know there was at least probably a couple questions on this type of deal. So definitely something to know. Now here's the chart I was talking about. Okay, so notice here, it basically says the same thing as that slide back there did. It's just a nice, easier way to look at it. So the acidic drugs here, of course, that the pK of that drug is higher than the pH. So relatively acidic environment, and it's unionized more than ionized, so therefore it's able to be absorbed. Okay, if they're equal to each other, then it's going to be the ionized and the unionized, of course, equal each other. And then ionized is going to be much higher in the case with a alkaline environment for an acidic drug. So I just thought this was like a super nice table to sum it up for you guys. The only thing that really gave me trouble was the whole pKa pH deal. But like I said, I hope it helps you sort this out. So that's why I have this down in the notes. Anyway, so plasma protein binding. So this is a different concept altogether. Basically, all this is saying is like the definitions between like a free drug and like a not free drug, kind of. So only a free unbound drug is free to distribute throughout the body. So that's the only way it can be kind of calculated in with volume of distributions if it's a free drug. Only free drug is free to act. Makes sense because it's not bound to something else, so it's able to actually do its action. Because a lot of the times it's bound to something, especially like albumin, in order for these drugs to get to certain places that they need to go. So that's kind of what this is talking about. So if it's bound to albumin, for instance, it's not actually a drug, a free drug, until it gets rid of that and binds to what it needs to bind to. And only free drug is free to be excreted, because, as you know, albumin being excreted, not typically a good thing. Okay. Only free drug is free to be metabolized. Makes sense with everything else that we're talking about. All right. Then on to barriers. So this talks about just a couple barriers that are a little bit more important than the other ones. So one of them is the blood-brain barrier that we're talking about. And that one's a very picky barrier, as you guys might remember from like MFM, maybe even like anatomy or something like that. Definitely MFM, I know for sure. But anyway, it's a very picky barrier, and it's only going to allow small, very lipophilic, so of course like fat-loving molecules that will be only able to enter the brain. And the reason for that is because it's not fenestrated at all. It's like very locked out. I mean, it even has those astrocytes with those like little foot processes all over these things. So I mean, it makes total sense that it has to be like a really small, very fat-loving molecule in order to get there. Now on to renal tubules. So in order for the renal tubules to take that up, it has to be like non-ionized. So if it's non-ionized, it can be passively reabsorbed. Of course, that just means like reabsorbed with no energy. All right, now volume of distribution. So basically, what volume distribution actually is, it's just a theoretic volume that a drug occupies in the body. And the way I kind of think about it is, it's kind of like it's saying, it's not like a real volume. It's not like how much water is in your system, right? The volume of distribution is kind of like the range of the drug, like how far it can go out, and like what space it can occupy. That's the way I kind of think about it. Um, but yeah, so it's a theoretic volume, not a real volume, and it's the space that the drug actually occupies in the body. I included this slide because I think there actually might have been some weird question on this. Um, but she didn't have anything in red, or maybe she did have it in red somewhere else, and I just didn't pick up on it. But something about like if you take, so say you're trying to see how much of a dose somebody actually has in their bloodstream, you don't want to take it like very soon. You want to take it later during this like elimination type phase. You don't want to take it during the distribution phase because that will show up like a lot higher than it should actually show up. And that's sort of what this is saying, but I know that's what the question was kind of pertaining to. And I mean, for all I know, it might not have been on this exam, but I definitely remember it showing up somewhere. So that's the only reason I kind of have that slide on here. Clearance. So, and also another thing to notice. So once we've gotten to these, she mentioned the things in red here are like the units for these things. So, of course, that means definitely know the units for each of these, and of course what they kind of mean, right? So clearance and elimination, they're kind of like the same mechanism in a way. That's the way I kind of think about it. It's clearance and elimination. They're kind of the same. Um, and that's measured in volume cleared per unit time. So make sure you know the units behind that and what clearance means. This one is super important, this slide, to know the difference between zero order and first order. That will definitely be a question on there in some way, shape, form, or fashion. Definitely ask it somehow. Um, but anyway, so zero order kinetics is where the drug leaves at a constant amount. So, for instance, maybe it's like 10 milligrams per hour, like the example says, right? And so therefore, that example, since there's 85 milligrams of drug X, it's going to take 8.5 hours, right? Because it's doing 10 milligrams every hour. Okay, so that's what a um, zero order kinetic drug looks like. And on a chart, it would be like a straight line. Like it'd be a lot straighter than a first order, which is like more of a logarithmic type graph. And there also could be a question pertaining to what the graph looks like, but we'll cover that when we get to it. First order, so that's of course different from zero order in that it's a proportion of the drug that leaves at time. So that's where we talk more about half-lives. And so you use those half-lives to kind of measure that excretion or that clearance. And then, of course, you could do that example if you wanted to. But basically, what's happening is every 3 hours, you're losing half of that. So in 3 hours, from 100 it'd be to 50, and then down to 50 to 25, and so on and so forth for every 3 hours, right? And that's what that's saying. And then that's it for that one. So pretty quick. Now to pharmacokinetics, so lecture 3. Elimination, like I said, I think a lot about it in terms of it reminds me a lot of clearance, but it's not the same thing as clearance. And notice by this formula right here. So notice it's not exactly the same thing, but it's a similar concept. But anyway, the thing that's important on this slide is what's in red, and it's super high yield, guys. Like I think I remember this being just like a first order type question, or maybe I think it was like asking like how many half lives would it take to get to steady state, and that's what this is. It would take 4 to 5 half lives to get to steady state. And of course, this happens in first order kinetics because that's the only kinetics that actually measures half lives. Because remember, zero order is only doing amounts, right? It's not proportion. Now on to a different concept. So elimination rate concepts, constant. So that's actually on this last slide, but it didn't really go much into detail until this slide. So the elimination half-life, we've already talked about. It's just the amount of time it takes for the concentration to decrease by 50%. Totally makes sense, right? With it being called half-life. And this gives you kind of like a little formula to figure that out. From my recollection, I don't think we had to ever determine the half-life from a formula at all. I don't think we ever had to do that. But we did have to, at least I have it written down somewhere that she said it was important to do, is to be able to see from a graph like what half-life, like when you've achieved a half-life. Like what I mean is like, see this top graph here? So notice that the concentration starts at 10, right? And then you see it goes down to 5 right here. Well, then that means its half-life is 2 hours. Okay, so that is something that you definitely need to know. And I wrote down, and we probably did have a question about it, I just don't remember it. Then on to another thing talking about units, and another formula that I'm pretty sure that she didn't do that. And this is that same graph that I just gave you an example of. That's why that star is here. I just didn't see it on the last slide. But yeah, so make sure you're able to do that I just did. And by the way, if you ever do have any questions at all, you can always email me. I'll put my phone number at the end in the chat, so you can always text me if you want. Of course, if you're friends with me on Facebook, or you're not, and you can be friends with me on Facebook, you can message me that way too. I'll be available to answer your questions in any way. Clearance, once again, that's liters per hour. We've kind of already talked about that one. Half-life, makes sense that one's in time, right? And then KEL, so that's your kind of like 1 over an hour. That's what that is. And then liter, so that's VD. And then, so maybe she did have a question about, maybe, I know she definitely had a question maybe about units, but I don't know. I don't think we ever had to calculate anything, but just in case, I would probably memorize that just in case. Once again, the reason I included this was because I thought I would kind of give you like a nice little practice maybe in terms of like determining what the half-life would be in this case. That's why I put it down here, bold and underlined. Look at the graph and tell what the half-life is. So just be able to do that. Zero order elimination kinetics. So this slide just gives you kind of like examples. That's why I thought it was important to know. So aspirin and ethanol are the two classic examples that she may bring up on the exam. So make sure that you know aspirin and ethanol are zero order. Now here's this graph I was talking about. How you tell the difference in terms of a graphic like illustration between the two. So a zero, like we've already mentioned, zero kinetics, it's going to be a straight line. And as you can see on here, it's a straight line, that blue line, right? While your bucket F here is first order. So that red line, that's going to be more of a logarithmic type graph. Okay. So for all you know, she could just bring up like the graph, could be a first order type question. Um, but yeah, so make sure you know what they look like graphically, know what examples of zero would be. I don't think she mentions a specific examples of first order, at least that I found. So make sure you just know that aspirin and ethanol specifically zero kinetics. Now on to this. So this chart is super duper important. I know there was like 2 or 3 questions on this puppy, like pertaining to this sort of thing. And it makes sense when you work through it. Like you have to really kind of like sit there and read through it. I only know that because like I was like, what in the world is this thing when I got back to it because it's been so long. But it does get a lot better when you kind of just read each row at a time. And so how it's separated is this A section is things that lead to an increase in that particular drug activity that's talking about in this left column here. And then this bottom right here, this red part, is where you get less. So this would be a decrease in drug activity instead. And I'll just run through a couple of them. So say you have like an active drug that's that's metabolized by the CYP. So what CYP is basically like it's like a protein complex that like breaks down drugs typically. Um, and so anyway, so say it's just an active drug that's kind of already done its process, right? And then it gets metabolized to become inactive by that CYP enzyme. Okay. And so what the example says here is that say there's another drug, like a precipitant drug, that has the effect of inhibiting that CYP. Okay, so say that CYP is now inhibited, what happens? Well, since that active drug is not is broken down by CYP to form that inactive metabolite, it's no longer able to do that because that CYP is inhibited, and therefore it's stuck in the active drug formation. Therefore, you have accumulation of that particular drug, therefore drug toxicity. Um, so that's just one example of that. And the other ones you can just follow through the exact same way. Um, Once again, if you have any questions, I know it is a little confusing sometimes with this chart. Now on to this one. I'll give you an example of that. So say it's the exact same thing, but in this case, it's an inducer. Okay. So say it induces that CYP. That other drug induces that CYP effect. And so therefore you have more active drug becoming metabolites, like inactive metabolites. And therefore you have a gradual loss of activity because you're going into clearance too fast, essentially. And so therefore you have to like up dosage and stuff like that if that were to happen. But yeah, I would say it'd be nice to work through it and make sure you understand what this table's saying. Um, and everything. Oh wait, it says I got a new message. Hold on. What is the difference with language? The language in the first and the third. Let's see. Inducer that stop. Well, that's one. Well, first it says it's an inducer, so I mean that's off the bat the difference. Um, let's see. As active drug metabolized to inactive by CYP. So that would be an inducer that is stopped while object drug at steady state. Hold on a second. Inducer that is stopped while object drug at steady state. I guess because it's like since it's already at steady state that it makes it different. Um, that one is kind of weird though. Inducer stopped while object drug. Oh, wait a minute. Oh, because the inducer. Oh, that's what it is. Okay. So what it's saying is that this active drug, since it's normally right metabolized by CYP to form that metabolite, right? In this case, that drug that you give, this precipitant drug, it would actually like lead to the stopping, like that inducer tends. Oh, okay, yeah. So the object drug has already hit like steady state or whatever. That's what it's saying. So you know how it says object drug up here. So object drug's already at steady state, and therefore, like this precipitant drug is typically an inducer, but it's actually stopped in this case. So therefore, what will end up happening, since it overcomes the precipitant drug effect, it'll lead to a gradual onset of toxicity. So notice this is like a gradual onset instead of like an automatic accumulation. So I guess that's the difference between the first and the third. Does that make a little more sense? See, I know she didn't ask anything about that third row anyway, because she really is not a tricky person when it comes to exams. I've never really had an issue with Dr. Weaver. Um, so I would say that third one's probably a little bit more low yield anyway, just because it's a little bit confusing the way she has it written anyway. Definitely, I know we had, I think it was an example of maybe one of these two or one of these two for sure. I know that for sure because I remember having to pick that it was a CYP inhibitor or an inducer or something like that. Um, but yeah, I hope I explained that good enough. Sorry about that. All right, now on to this thing. It kind of gives you like real life examples of kind of what we talked about just a second ago. The thing I thought was kind of important down here is the thing she has in red. So some of these drugs, some drugs undergo multiple routes of elimination. So they're able to kind of like bypass this whole CYP mechanism sometimes because they're able to use other enzymes in other places. So that's kind of what this is saying. There are drugs that may be biotransformed into active, inactive, or toxic compounds. So that's something else. Some drugs are excreted unchanged. So what that means is basically there is no active and inactive phase. It's just the same phase. It's just not toxic, basically, if it gets accumulated for the most part. Some drugs are administered as prodrugs, designed so that way. So this would be basically like if you remember back with GI, right? That you guys just had. You know how like those pancreatic enzymes had to be like sliced right in order to become active. So that's like the same concept. So basically, they give you the drug before it's sliced, quotes, and therefore it turns to the active drug. So it's just giving you a different examples of how different drugs work. That's kind of what that's talking about. Now this is also super duper important. Notice the rare 3 stars, guys, rare. Okay, so super important is the acetaminophen toxification along with the ethanol. Okay, so that's what causes this whole process to occur. Okay, so that's just telling you straight up forward before you like really dive deep into it. Okay, so what happens here is that there's a major and a minor pathway, right? So we'll start off with acetaminophen first, right? So acetaminophen, it could choose either this major pathway, which basically just means that's the main pathway it's going to choose, and therefore it's just going to get renally excreted, have no issues whatsoever. So it's broken down into sulfate, glucuronide, and then excreted via the kidneys, no problem at all. Okay. Now, normally it does have this minor pathway, like it does occur, but it doesn't occur to the point to where it's toxic. Okay. But in the case of a CYP2E1, so you have to remember that specifically CYP2E1, by the way. So make sure you know that number letter combination. Okay. So that gets turned on or induced to be activated more often, basically, by ethanol. So that's where ethanol or alcohol, right, comes into play. So what it leads to is that overactivation of that minor pathway, And this pathway, this minor pathway, is much more likely to be toxic, especially this bottom right here. So notice it says hepatic necrosis. That's the pathway you definitely don't want to go. And what depends on that? So then this minor pathway leads to this thing called NAPQI. So that's the way I'm going to say it. Of course, it's like a lot longer name than that, but I'm definitely not going to get into that. And then what happens here is there's a fork, right? So either you have glutathione, which is like it's kind of like it's like an amino acid um, kind of molecule. So anyway, if you have glutathione, it's actually more like a vitamin. But anyway, if you have glutathione, then it becomes this thing here. So that's what it becomes, and therefore it gets renally excreted. But however, if you have malnutrition, so therefore you don't have any glutathione, then it becomes then you can potentially lead to, if there's too much of it, hepatic necrosis. Okay, so basically the worst case scenario with this is somebody that's been taking acetaminophen that is malnourished, okay, and then they had some alcohol with it. So that's where you have like the worst of the worst situation. So make sure you know and understand all of that because I think there was a question on it. Um, and then N-acetylcysteine, so this little blue box over here. So what this actually does is it's like a drug that you can kind of use to stop this process a little bit. So what it does is it actually detoxifies NAPQI, so this thing, and it does that via its SH group here. By the way, I do have probably more detailed notes about what's going down um, in here in terms of like what's actually going on because I know like I think she explains it fairly well anyway. But APAP, by the way, is just another way to say acetaminophen slash Tylenol. That's what APAP is. So in case anybody's confused. But anyway, just make sure you know this mechanism. Now on to another one that I know it was asked at some point, and I did fill this in for you, by the way. So I didn't put it bold or anything. So I do have the answers for that already on there, just in case you guys didn't get that through lecture. But anyway, so um, it just basically tells you that grape juice um, it like inhibits this 3A4. Make sure you know this 3A4 and what the process like means. I'm not going to go through it, but if you guys have any questions about it, because it's a little bit more low yield, I don't know if they asked anything about it on this exam per se. But just make sure you know that's 3A4 grape juice, and then just read through that paragraph for for that slide. And then on to this part. So this is yet another example. The reason I included all these is because they're like really good examples. That one's just super important. I feel like she had a question on this one, but I'm not sure. But this one, I just thought was like a really good example. And the reason that I put down here, it says mark the first two out immediately, is because so when you read through it, basically what happens is this person has AIDS and they take ART drugs. So that's kind of like the drugs you would take if you have HIV or AIDS. Um, and so that's acting through 3A4. Not really important to know with 3A4 on this example per se. So it's not something that I really remember, but it's just like a good example about what kind of things she could ask. Okay. And so, say they have St. John's wort, so say they take that, which is a 3A4 inducer, like what would the chart look like? And notice here she says pay attention to the axis in the units. And the reason you would do that because, I mean, if you're like me, you want to automatically think they put time and like kind of the concentration of drug on the y-axis here, but they don't. They put the viral load on the y-axis. So that's why it goes up instead of down. So make sure you understand that. And of course, since it's a inducer, it's going to lead to more of that inactive metabolite being formed, and therefore that viral load goes up. That's basically what's going on there. Then this kind of like relays back to how we were talking about acidic drugs versus alkaline drugs, and like how their transport is affected because of that. So you remember how, so aspirin is specifically an acidic drug, And this is basically just kind of giving you a way to think about it, but I'll kind of walk through it real quick. So aspirin's an acidic drug. So what happens to the amount reabsorbed when you alkalinize the urine in the nephron? If you were to do that right, since that acidic drug's in a basic environment, it's not able to be reabsorbed because it's ionized, right? In that case, so therefore reabsorption would go down. Makes sense, and therefore the amount reabsorbed would go down. How does this affect the clearance of aspirin? It actually would make the clearance a little bit better for aspirin because it's being eliminated out of the body, right? Because it's not being reabsorbed. So the clearance would be better, but its reabsorption is not. What if you acidified the urine? Well, then of course that would make more unionized aspirin be available, and therefore more would be reabsorbed. So, and I don't know if I don't know if I wrote that down in here. Yeah, okay, I think I did a little bit. So make sure, maybe she did. I don't really remember. The reason I put Shift F5 is just because it gives you like a little animation if you actually do Shift F5 on this slide. And what that Shift F5 is just a shortcut to get to that slide in PowerPoint mode, basically. Now on to talking about steady state. The reason there's 3 stars is because that how many half-lives to steady state thing. That's notice how many times it's been brought up. By the way, it's like 3 or 4 times at this point. So it's an important thing to know. Just make sure you know that it's 4 to 5 times. That's how many times it has to go through half-lives to reach steady state. And of course, this is first order elimination because that's the only ones that have half-life. And then things to note about steady state, kind of like how it's determined, is that time doesn't really have anything to do. I mean, the the time to steady state, so like how long it actually takes to get there, it doesn't matter with dose. So dose is not going to like control that at all. What it depends on is how fast it's cleared or how fast it's eliminated. So basically, in order to reach steady state faster, you would have to basically decrease elimination. That's really the only way you could reach steady state any faster, theoretically. And in steady state, just a definition of what that is, she puts, is when the rate in equals the rate out. So that's what that is. And then I think there might have actually been a question on like a loading dose. That's why I put 2 stars on this one. A loading dose, what that will do is it will shorten the time to achieve steady state drug concentration. So notice that's underlined. Steady state drug concentration, but not actual time to reach steady state. Okay, because steady state and steady state concentration are 2 different things, right? Because it's a dose dependent process. Um, so what, and that's because once again that clearance is what matters in the case of determining when you've hit steady state. Okay, so that's kind of just to relay that point. So if you were to give somebody like a dose, right, of something, like a loading dose of something, you're not going to actually hit steady state any faster if you give more of a dose. The only way you could is if you control, once again, like I said, clearance. All right, now on to lecture 4. All right, so this one's a pretty easy concept. I know you've heard of tolerance before, probably even an undergrad before. Tolerance, what it means is it's just a higher dose is required to produce the same effect. That's pretty easy, pretty simple. I just included it because it was red tape. All right, once again, kind of a simple, obvious thing. Patients can be dependent upon a drug without being actually addicted to the drug, and that's just because physical dependence. So dependence, of course, is different from addiction. So addiction would be like, it's like if it really has an actual effect on your life. Like if you just can't wait to get the next high or whatever, that would be addiction. But dependent is like when you have like your physiologic response, right? It's like your body just feels it and you need that drug. That's what dependent would be versus addiction. So it's not the same thing. All right. Now, the reason I have this one here is because I think it's a very good slide for helping you understand potency. and also like what that has to do with EC50. So make sure you know that like how to determine from a graph which one is more potent. And they'll give you something very similar to this on the exam. So they'll give you something like B, right? For instance. Okay, so you see drug A and drug B, right? So the potency differences is due to the graph moving horizontally. So notice here that drug A is more to the left and drug B is more to the right. And the only reason it kind of matters is because the drug concentration is on the bottom, right? So therefore, the smaller this EC50, so basically what EC50 is, it's like it's the concentration at 50%. So it'd be the drug concentration at 50% of the maximal effect. So E max would be way up here. EC50 is like right here, right? Because it's 50% and it's the concentration at that 50%. That's what EC50 means. Okay. And so since this EC50 is smaller for drug A, it takes less of that drug to reach that 50%, right? So that's what that's saying. Because notice that this line's before the other one. And so therefore that EC50, since it's lower, therefore it takes less concentration of drug A to reach the same point that it takes to reach that same 50% at drug B. So the more left it is on these types of graphs, the more potent they are. All right. Now this one's important because I thought this nice little like top right graph, I thought it was like very helpful for the stuff coming up. Um, so and also just it kind of explains differences between this. So that's why I included this one. But basically, so notice, so we'll start off with so just A alone, right? So that's just the agonist. Okay, so the agonist, it's going to have, it's rise up to the Emax. So this is the Emax of A just by itself. So that is the effect that it by itself will only do. Okay. Now, say you were to add something like C. C, notice, is an allosteric activator. So what allosteric means is that it binds somewhere else that the agonist does not bind. So it's like a separate binding site altogether, and therefore there's no competition between it and the actual agonist. So therefore, since it's an activator, it's going to basically do a synergistic effect. So therefore, you'll have a higher Emax than just with A by itself. So make sure you understand that. And then A plus B. So notice B is a competitive inhibitor. And so you notice that it's at the same binding site. So it's a competitive like antagonist basically. And so what it's going to, or it could be even a partial agonist, which has a similar effect as like a full antagonist. Okay. But anyway, so that competes with the agonist here at that site. And so therefore, notice that the difference, okay, make sure you know this because it is a little confusing, that since it's a competitive inhibitor, it's actually, competing with this binding site. That means at some point, if you were to just increase agonist so much so that it outcompetes the competitive inhibitor, that you're going to reach Emax no matter what, but it's just going to take a larger dose to do that. So that's why, you remember when we were talking about EC50, it takes a lot larger EC50 to get to that Emax, right? So, and the reason it does that is because it's competing with that same site, okay? And so therefore, if you have so much of the agonist, you can eventually outcompete and get to the regular Emax. Now, with A plus D, however, that's a totally different thing, right? Because it's its own different binding site, right? The allosteric inhibitor, same, concept behind the allosteric activator, how it has its own binding site, but of course it's an inhibitor in this process, right? And so therefore, it's able to have no competition whatsoever with the agonist. So no matter how much concentration of that agonist you give, it's going to hit a different, very low Emax. Okay? So make sure you know the differences between these and what those charts would look like. Because what they'll do, they'll give you an A alone type graph, and then they'll give you one that looks like A plus B, or one that looks like A plus C, or so on and so forth. And they'll ask you what kind of thing that molecule is that you added along with B. So, I mean, along with A, my bad. So, for instance, the answer for the A plus B, if it looks like that, would be a competitive inhibitor. So, that was definitely a type of question that you want to ask on there. Okay. Now, I included this, but like honestly, I don't really know what was super important on here. I guess because it's kind of similar to the last picture. So, and the only reason I guess that I included it, I included this one because it has partial agonist on here. So it kind of gives like a little bit better verbiage. So it tells you the little differences between partial agonist and antagonist. So notice that there's a full agonist, right? So that would be like A by itself, like we were talking about earlier, right? But in the case with like a partial agonist, right? If you were to add like say a substance B that um, still activates the same, so it goes to the same binding site, so it competes with the actual agonist itself, and so therefore, since it's a partial agonist, you're having less of a response altogether, and therefore you're going to have a smaller Emax, even though it's still activating like the same exact pathway, and it's an agonist. It's just a lot weaker of an agonist, so therefore your Emax is going to be lower. All right. Now, in the case with like an antagonist, right? Notice that it like basically flatlines it, and that's because it's like it has the affinity for that receptor. So notice it says it in bold over here for you. Notice that it has the same affinity as that agonist. So it has an affinity for that receptor, but there's no actual activity going on. And so basically what's happening is that antagonist blocks that whole receptor, and therefore that agonist can't latch on at all. And so since it's an antagonist and doing the opposite of that agonist, then it's a whole lot less activity, and basically no activity at that point. And then inverse agonist, I wouldn't honestly worry about. She never really went on the details about that. So skip by that. This kind of just goes more into detail about kind of what I was talking about. Um, this gives a good example, a good slide of like potency. And also it does, so this would be a full agonist combined with varying concentrations of irreversible antagonists. So make sure you notice like when they give an irreversible antagonist that eventually, so you give so much of it, right, that the Emax actually changes. Okay, so make sure you notice that you have a full agonist and you give an irreversible antagonist. Over time, it's going to lead to, um, so say the more you give, it's going to lead to more of a flat lining of Emax. All right. And then this, I've kind of pretty much already talked about this. So what this is competitive antagonist. It's kind of like the example back here with this. So your competitive antagonist would be like B, like the one A plus B. While the allosteric or the non-competitive antagonist, right? Because and the reason it's not competitive is because it's allosteric, so it can bind somewhere else. So therefore it's not competitive. Therefore that Emax is going to be actually messed with. So notice with this agonist and competitive antagonist, it could still reach Emax. It's just going to take a lot longer to get there. And then putting it all together, this slide's a very good slide in terms of just telling you the difference between potency and efficacy. So by efficacy, what they mean is just Emax basically. So for instance, if the blue line was a drug by itself and the red line was a drug by itself, this one, the blue line, would be much higher efficacy than this one. So, and then potency we've already talked about, so it has to do with EC50. So in this case, drug A would be the most potent. Right? Once again, it's just another example. I put the answers down there for you, like in terms of how you determine it. So more to the left, then it's going to have a lower EC50, and therefore it's going to be more potent. But however, if the overall graph reaches a higher point, then it's going to be that higher, the one with a higher point is going to be efficacy is going to be higher. So therefore, it has a bigger effect. Um, and then this talks a little bit about like partial agonists, how like it can act like an antagonist when combined with full. And notice once again, it looks a lot like it honestly looks a lot like an antagonist, like when you add it onto it. It's just not going to have like as strong of a response as an antagonist. It's going to be a very similar response, but not the same. This I included just because it gives you kind of like an upfront what a therapeutic window looks like. She doesn't have it in red or anything, but just in case that, like you've never heard of a therapeutic index or a therapeutic window of any sort, it kind of gives you a good example. So basically, what you're going to do is you have your concentration that's like a therapeutic concentrations. Then you're going to have this concentration that's like way too high that leads to adverse effects. So basically, side effects. And so what happens here is like you'll reach this point right here. And so like right in here is like where the gray zone kind of happens, right? Where it's like, this is much more safe. This is kind of like not really sure. And then if it gets past that, then it can lead into adverse effects. And then notice if it gets way too high, then there's no even therapeutic effects even more. It's just way more toxicity than there is effects. All right, once again, kind of brings up the difference between side effects and like an allergic response, which is like the same, kind of the same as what an idiosyncratic effect is. So side effect, it's going to be more dose related, and it depends, of course, on your target effect. While idiosyncratic effect is more unpredictable and it's not dose related. So just make sure you know the differences between those two, and that allergy is an example of idiosyncratic. All right, now on to pharmacogenomics and pharmacogenetics and all kinds of junk. It's a really long title slide. So this one, I think this is the one with like different examples. Okay, no, we already passed that one. Okay, but anyway, so basically this gives you like an example of opiates in CYP2D6. I want to say that there was like a question like similar to this, maybe in concept. I don't know if it was like asking about 2D6, but we're just going to skip this part. So this kind of gives you like the vignette or like the stem for it, but it doesn't really matter anyway. So basically what ends up happening is that she takes like two drugs that end up like blocking these other pathways. So she's got clarithromycin, and then she's got valproic acid, so that's your VPA here. She's taking those, and therefore these ones with the yellow X's here, they're all blocked off. And on top of that, she's got a phenotype that leads to like 2D6 being activated much more often. So that's another CYP mechanism. So CYP 2D6. And so since these other pathways are blocked off, and in the example, by the way, she took hydrocodone or oxycodone, something like that, right? Which is like a much less much less potent opiate, versus, of course, like hydromorphone or oxymorphone, right? Which is in this left box here. Okay, so what happens since she has this ultra 2D6 and these other pathways are blocked off, then it's going to lead to basically hydromorphone, oxymorphone, and morphine being formed whenever she takes these drugs. So therefore, super bad toxicity is not good, right? Maybe the only thing I would need to, I know it's an example, but the concept behind it's very important in terms of, like if this is blocked off, it's kind of like another one of those table examples. It's kind of similar, but maybe it would be worth knowing 2D6 for that. I know she didn't put it in red or anything, but just something reminds me of that. So I would just memorize all these CYP enzymes just in case. But yeah. And then this is super duper important. Anytime she mentions irinotecan and Gilbert's disease or syndrome, like you gotta know it. Okay, it's 100%. It probably be on there. Like I hate to say like 100%, maybe more like a 95%. Okay, so make sure you got that with you. Okay, so basically what happens here is I think it breaks you down based upon, let's see, when UGT in the epithelial cells of the intestine is defective. So UGT is this enzyme that like basically breaks down a metabolite. that's made by irinotecan. Okay, but anyway, so when UGT in the epithelial cells of the intestine is defective, then that toxic metabolite of irinotecan ends up accumulating and kills the gut epithelium, leading to severe bacteria. I mean, not bacteria, diarrhea. Okay, and that's where she gets this like catchphrase, the "I run to the can." It's something to like help you understand, remember that leads to basically like very severe diarrhea that can actually end up like being deadly. Okay, so death by diarrhea and/or neutropenia in patients with Gilbert syndrome. And the reason that it's more severe is because you actually have a complete lack of UGT. So basically, if you take irinotecan and you have Gilbert syndrome, then that UGT, since Gilbert syndrome is not even working, right? That UGT is not working, then it's going to lead to a bunch of that toxic metabolite from irinotecan, therefore lead to that very severe diarrhea and therefore death, possibly. I would also know, it says it on the next slide anyway, but I'll just tell you ahead of time. But I would definitely know the metabolite in question. So I would know CN38. That's the metabolite for that. And she does mention it on the next slide, so I'll go ahead and get to that. Also, might be worth, the enzymes were like actually named UGT, but just in case you don't get yourself confused or something, there are sometimes as like other numbers behind that. So notice on that diagram it has UGT 1A1 and 1A7. Okay, that's just different like isoforms of the same protein. So same problem, just slightly different form of the protein. But yeah, no SN38 is that metabolite that gets increased. No UGT is the one that's messed with in terms of Gilbert syndrome, and know that if UGT doesn't work, you get that deadly diarrhea. Once again, this is kind of one of those slides that I don't think it was very important, but she does have in red. So inacylation. So these are all the drugs that actually use that process for breaking down. So sulfonamides, hydralazine, isoniazid, and procainamide. So all of those are SHIP. Okay, you can use that acronym. All of those go through inacylation. And something else they have in common is that they can actually cause an autoimmune disease that resembles lupus. And if you guys kind of remember, maybe you guys know a little bit about lupus. So lupus is like the very common thing you see on there is like a butterfly malar rash. It's hard to really like describe what that looks like. It's like a big rash, red rash, like on their cheeks. That's like the very classic example. So if you see anything like that on the exam, like that's just boom, 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 right in your face like that. That's what they're talking about. They're talking about this stuff. So because it resembles lupus, right? So just keep that in mind. Of course, there's other stuff that goes on with lupus, but that's the thing I always think about. And they typically have that in the question stem. Now on to G6PD deficiency and hemolysis. I bet you guys like really love G6PD at this point, like we all did back last year. It's like you just hear it all the time, right? Just can't escape it. But anyway, so once again, left the case in there, but not super important. The thing I thought was kind of important, she says FYI, but I know it comes up at some exam. Maybe it's not this exam, maybe it's some other exam. But I know it is important to know at some point in Pharm, the whole G6PD oxidation damage type deal. Okay, so basically, just to sum it up for you, you can read through this, but G6PD is, so you'll lead up to a lot of oxidative damage within these RBCs, like the red blood cells. And so therefore, you have a lot of lysis with that. And so if you take any drug that leads to more oxidation whatsoever, or you even eat anything that's highly oxidizing, like fava beans, okay, so say you do that, then you're going to have a much stronger problem on your hands, because you're going to have that lysis that already kind of happens, especially if it's a more severe version of G6PD, like the Mediterranean version. But if you have that on top of taking the fava beans or even primaquine, primaquine, I think is how you actually say it. Say you take that and it's a highly oxidative drug, then you can lead to a lot larger RBC lysis. Okay, so that's basically just to sum it up. Um, it's X-linked recessive, so males are more likely to get it. And this is like the recycled slide from MFM1, so that's just like really breaks it down for you. And then here's some like application questions that if I had more time I'd go into, but honestly we need to kind of like pick it up a little bit. If you do have any questions at all about these, I felt like she covered it pretty good down in the notes section. But if you do have any questions at all, be sure to just ask me and I'll totally fill you in on it. Basically, what it has to do is you have to know the pKa's of these and if the drug's an acid or a base, basically. That'll help you eliminate the answer choices. And then I've left this in here just in case like you're using just primarily this study guide or something for the test and you want to make your own practice questions. That's the only reason I have that in there. This gives you like a good example of what we were just talking about with G6PD. The reason that you know it's G6PD is because it has these bite cells here. That's what they call those. I think degmacytes is like the real word, but don't quote me on that. But anyway, so, and it's probably supposed to be pruritus, itching. Okay, but anyway, that's what's going on here. I have the notes are pretty much filled with that, but it's just another example. I thought this was a very important slide because it kind of gets you thinking about what ED50 and TD50 and all that is. And I have all of those answers, by the way, down here filled in for you. Except for that, I think the last one she had automatically down there for you. But I filled in the rest of them, so there it is for you for later. But ED50, we've already talked about ED50 basically. Very similar to EC50. Well, it's more like the effective dose. That's what ED means. And that's the dose at which like 50% of people will respond. So that's ED50. TD50 is, of course, it's going to be toxic dose, right? And so that's a dose at which 50% of people have toxic activity or whatever. What does therapeutic index tell us? So what does that actually tell you? Right here it says the relative difference between the average toxic dose and the average therapeutic dose. And notice right here there's a formula to calculate that. There might have been a question on the exam asking you to calculate therapeutic index. But of course it's like a very simple, it'd be like a very simple math problem. It wouldn't be anything like they'd have to have a calculator for. And once again, that's on here on the slide, so that's why I included this one. But I think there might have been a question on that, so just keep that in mind. Once again, this gives you another review of which one's more potent, which one's more efficacious. Now, of course, in this example, B is going to be the most potent one, while looks like D maybe, D or C, it's hard to really tell honestly. Those are way more efficacious than B. Now in this, so once again, she just has like a lot of examples built in here, and I'm just gonna skip through this because at the end of these like 3 or 4 slides, it gives like a summary of them all. And I do put like in all of them like which effect it's talking about and like kind of what's going on at the very top. I think in most of them, I don't think I did it on this one, but anyway, this sums up like all of those. So you don't have to really look at all those separate, but it does kind of tell you in more detail what's going on in the notes with those. But anyway, so competitive antagonism, we've talked a lot about. Basically what happens there, right, is it competes with the same binding site, and so therefore it's still able to hit Emax, but it won't hit it as quick. And allosteric, that's a totally different one, right? So therefore you notice that Emax get gradually worse. And then pseudo-irreversible, that one's kind of a weird one. You don't really hear a lot about. So that's a non-competitive antagonist. So that one, it's like you notice it seems like a much more rapid. And it can like go all the way down flat. The pseudo-irreversible. Okay. Make sure you notice the difference between this one and this one because that's where it gets tricky. Because these two look a lot alike. Okay. So notice pseudo-irreversible goes all the way down to almost flat. Allosteric, it gets to a certain point, and then the drug's still going to have its effect. And then allosteric. So this is actually talking about potentiation instead of antagonism. So this would be more like a synergistic effect in between A and P in this case. Once again, another example. There's a lot of those. I just thought it might help you guys out if I just left them in there. What would happen if you gave methadone, buprenorphine? Yeah, and it just tells you like that buprenorphine's a partial agonist, so therefore it's gonna like have just a flatter E max versus it just tells you the difference. Um, and then this is a zero order, mainly because you gotta look at the x's and the y's axis at all times, right? And it's a straight line. Straight lines typically, of course, you do have to read the axis. They're gonna be typically zero order almost every time. But yeah. And then intro to antimicrobials. This is like a very like short one. Honestly, it seems almost kind of random. I left this slide in here because like I know when I was looking at it like back last year, every now and then I would get kind of confused in between MIC and MBC and like bacteriostatic and cytal and stuff like that when I was kind of studying late at night, so I just left that in there. But MIC is like the lowest concentration that antibiotic works, basically. And MBC is like the lowest concentration of antibiotic that kills like most of the bacteria. So that of course would be a higher concentration than inhibitory concentration, right? And bacteriostatic, of course, that like stops growth, while bactericidal kills actual bacteria. And yeah, nosocomial take care of. This one tells you the difference in between like what empiric versus definitive versus prophylaxis is. I don't remember there being a question asking like differences between those, but don't quote me on that. But anyway, it's a pretty simple slide, so I'm not gonna spend much time on it. Empiric therapy, so it just kind of goes a little bit more into detail. So what empiric therapy is actually is like this is the therapy that you initiate therapy after specimens for lab analysis have been obtained, but before the results are available. So that's what empiric therapy is. And the reason that you would do that before, like after the specimens have been obtained, is because you don't want to take the chance and kill whatever you're trying to determine is wrong, right? That's why you would do it after the specimens have been collected, but before the results are available because you don't want to take the chance that, say, it's something very lethal, right? You want to give them something broad spectrum so that it covers it just in case, right? And that's typically what you're going to give for empiric therapy. It's going to be a lot more like broad spectrum until you determine what it is, and then you're going to narrow the spectrum down. This one, honestly, I didn't really know what to think about this chart. I just left it in here because it might be a good reference. So that's why I have it in here. Once again, good reference. Not really a question based off of this that I remember, but probably wouldn't hurt to maybe know some of them. The ones that like stick out like Metro, or the ones that like are obviously only gram positive like Vanc, and then Metro is like only anaerobes, the ones that kind of stick out more. Time dependent versus concentration dependent. So that kind of tells you the difference in these concepts. So concentration dependent is an increase in the rate of bacteria killing as concentration increases. Pretty simple, right? So the more that you dump in, so the more agonist or whatever, the more drug you give, the more bacteria killing will happen, right? Versus time dependent, it's the increasing concentration is not really going to do anything, but that only increasing the rate of kill would do it. So it's time dependent only. And then static versus cytal, we've pretty much talked about. Maybe the thing she wants you to get out of that is like the aminoglycosides and the fluoroquinolones are specifically bactericidal. And anything that's cell wall active, that's, in my opinion, kind of a given. Because, if you get rid of the cell wall, well then, what else do they have? And then bacteriostatic, so of course that's going to be what's slowing down growth of bacteria. And sulfonamides and ribosomal agents are the ones specifically for that. And then she's got this concept known as post-antibiotic effect, so PAE. basically what PAE is the persistent suppression of microbial growth that occurs after levels of the antibiotic have fallen below the MIC. So remember, that's the like minimum inhibitory concentration. So at that point, if it's fallen below MIC, then that means that it's no longer having an effect, really, right? So that bacteria is allowed to grow, basically. Um, and so it's kind of like used by a lot. Yeah, so most bactericidal agents experience a PAE against susceptible pathogens. So it's just something that tends to happen when you use treatment. Um, this is also another important slide. So notice I have the stars here. I think there was actually a question, believe it or not, that literally said black hairy tongue on it, and that you were supposed to know that that's like a adverse effect to antibiotics. I think that was like no joke, like the question. So I would say it's probably an important slide to know. Now I don't know if black hairy tongue is gonna be if it's gonna be the exact same question or not, but I'm pretty sure that was our question last year. Something to do with a black hairy tongue. So this what this whole slide is basically just telling you the adverse effects that are common to all antibiotics. So yeah, it's not specific to bank or anything. It's all of them. So yeah, you can read through that. Black hairy tongue, specifically diarrhea, GI upset. A lot of them have those. And then resistance. The reason I have 2 stars on this one is because I felt like she might have asked like a question about like how, like what, like why is this drug no longer working? And I think maybe she gave like these as like examples or something weird like that. So that's why I have the 2 stars here on this one. But yeah. And then to prevent resistance, I have 1 star here because I felt like she had like a give me question that was literally like wash your hands. I felt like, but because occasionally she does give you like kind of like a give me one. Like I said, I really enjoy Dr. Weaver. She's a favorite of our class for sure. I'm sure she will be for y'all. Cell wall agents. Um, so from here, this is where I'm going to ask you guys, do you want me to continue on with this one or do you want me to wait till next time because it's more relevant? You just type in the chat which one you prefer. Doesn't really matter. Like I said, it doesn't matter to me. I'll continue either way. No, I'm fine. Yeah, I'm fine, Kami. Yeah, I'll totally continue. It's no big deal. Um, yeah, I'm sure you guys want just all summed up from this week. So, all right, sounds good. So I'll just go ahead and continue. Um, so I'll move the chat a little bit more out of the way. It's kind of bothering me why it's so close. No problem, Kami. So anyway, she always has these. So this is gonna be commonplace after. So this is the very first like actual like Pharm PowerPoint for you guys. So she's gonna always have this like drugs to know for now thing. A lot of the times, I feel like she doesn't pull so much from that. It's more so she pulls more from what she hasn't read. So that's something to kind of keep in mind. If she doesn't have it in red specifically, it may not be asked about. But then again, you may also want to take caution. So it's kind of like, you're kind of rolling with the dice on that one. But for the most part, I've always just read what's in red on her stuff for the most part. And of course, understood what was behind the red. So now we're on to like different types. So we're going to be talking about like different mechanisms and stuff like that. This gives you like an overall like bacterial cell wall. It tells you kind of what's going on with it, like what kind of mechanisms going on with the cell wall. And then there's agents that kill, of course, when the cell walls are synthesizing. So that's like a main target is that it's going to be like targeting synthesization, like synthesization. Now, there's no synthesization. What even is that? Synthesis of like the wall itself. That's a very common target for a lot of these drugs. Then murine monomer synthesis. So that notice on this right here, that's part of the peptidoglycan biosynthesis. So that's like one of the things going along with that. So that's why it's like important to know. And the thing she likes to ask a lot about, she likes to ask a ton about mechanism of action. Dr. Weaver loves to ask about mechanism of action. Okay, so pretty much anytime you see one in red, you want to know what the mechanism of action is. Okay, in this case, phosphomycin, right? That is an inhibitor of murine monomer synthesis. So make sure you know phosphomycin, inhibitor of murine monomer synthesis. Okay, and also the other thing in red that's here. Okay, so it's effective against gram-negative bacteria, specifically in the urinary tract. Okay, so say for instance, you have like a female come in with a UTI, right? The one you're going to commonly use is phosphomycin because the most common bacteria for UTI is E. coli, right? So yeah. Now on to a different drug category. So vancomycin. Vancomycin, right? It's an inhibitor of murine polymerization. So notice it's totally different, and it's a glycopeptide. That doesn't really matter as much as the mechanism of action. But specifically how it does that, that one's way more high yield. And typically they won't ask you the phosphomycin. Yeah, I'm about to say I don't remember. You know what's funny is like you say that, and I think we honestly had I think was it renal. I don't think we even talked about like phosphomycin for that. I think we talked about some other drug, but honestly it escapes my mind right now. um, some of the stuff kind of like goes in one ear and out the other. But yeah, it probably is a big gun. She probably just like mentions that specifically because it's like maybe an association you make with phosphomycin. Um, but yeah, I know you take. I can't remember what it is. Honestly, I wish I could tell you which one we talked about with renal. But yeah, it wasn't phosphomycin. It was something else. But yeah, so when you get to like second year and they like talk about specific pathologies, like for instance a UTI, they're going to go more in detail about like what more likely you would get. Um, like for instance, she'll still be teaching like some of the Pharm associated, but she'll give you like you know if it's this kind of individual that has a UTI, what do you give them? So yeah, I think for right now she's just really trying to like give you like super big picture. So I think that's really the only reason she mentions specifically phosphomycin. But yeah, she does mention other ones later. It's just it'll come back with like renal. But anyway, so but yeah, it's an interesting fact to know. But anyway, so vancomycin, so its main thing is going to be gram positive, pretty much only. I mean, it does have some gram negative, I think, but it's like very much so gram positive. And the very important thing to know about vancomycin is it's pretty much the only one that goes against MRSA that you talk a lot about. Okay, so if they come in with methicillin resistant staph, okay, if they come in with MRSA, right, then you wanted to give Vanc automatically. I mean, if that's an answer choice, that's pretty much the one to go to. Okay. And then, so I remember we had to know, yeah, like I said, the specific mechanism for this one. And she didn't ask outright what the mechanism for it was. She asked more like she asked more like she gave you a vignette, right, of somebody that had, for instance, MRSA or something, right? And then from there, she was like, what's the mechanism of action for the drug that you give? And that's a very common formula for Pharm questions. Is something like that. And that's even like board exams. They ask it a lot that way too. At least the practice questions. Of course, I don't know the real thing yet. But anyway, yeah. So that's the kind of thing they like to ask. Um, Vancomycin. Another thing about that is it's also used orally, but only like one time. And we literally just talked about this with the GI. So yeah, the only time they've ever mentioned oral vancomycin specifically was C. diff. Okay. Um, that and like fidaxomicin is like the only other one that's like specific to that. You can use Metro, but it's like a lot less often nowadays. Um, But yeah, oral vanc, C. diff. Okay, I would probably also memorize that for sure. Um, and also, she likes to also ask about every now and then. She'll ask about what the toxicities are, and I don't know why she doesn't have this one in red, honestly, because she asks about it all the time. Like I've had what the side effects of vancomycin is, like what the toxicity associated with vancomycin is, so many times I can't count it on my hand. Okay, how many times I've had it. Also, she doesn't have it in red. Red man syndrome. Red man syndrome also very common. So those three are super common. So nephrotoxicity. So that basically means like kidney toxicity, right? Nephrons. And then ototoxic. So that's more like ear problems. So that's gonna be like deafness or hearing loss of some sort. And then red man syndrome, I typically just kind of think of like an allergic reaction that's like makes you super red. That's what I think of. And of course, flushing and itching. I mean, itching, of course, associated with that. But once again, no oral vancs for C. diff. Know that's mainly gram positive. That it does MRSA. That's a big deal. Know what the mechanism of action is, and know the toxicities. Um, I don't think she's going to ask you anything about pregnancy or anything like that with this drug. And then beta lactams. This is like a very vague category because there's a lot under the umbrella of beta lactams. So you'll have, of course, penicillin, cephalosporins are even kind of underneath that. So yeah, it's just a very big category. But anyway, in general, they inhibit transpeptidase that mediates cross-linking. That's what beta lactams do. I don't know why I think lactams. But anyway, beta lactams. And then organisms that lack peptidoglycan cell walls are inherently resistant. Now, specifically, what are those? Mycobacteria and protozoa. Okay, and I mean protozoa aren't even technically bacteria, so yeah. I mean, I guess archaea bacteria maybe. Well, no, they're protists. Anyway, so these two types, they're not going to be covered at all with beta lactam. So if they were to give you lab discovers it's a protozoa of some sort, you can't give them beta lactam. Okay. I kept this in here because I know she mentions it all the time that like people miss this specific question all the time, and I don't honestly know which question she's talking about, but we'll go back over this here in a second anyway. But she breaks it down using this like house, garage, basement thing. So I have that down here for you, and you probably honestly, if you went through that lecture, you already have it down, jotted for yourself. But basically, she calls this like B part the garage and A part the house, and it tells you like, and then she'll talk a little bit about this lactamase here in a second. Beta lactam resistance. So honestly, I don't remember anything that's like super duper important, like that stands out on this slide. Um, but it is important to know anyway um, about the different mechanisms that these bacteria can use to get resistance. Did I skip? Yeah, I think I skipped one. Now the thing, notice again, MRSA is mentioned once more, right? MRSA is very important. Okay, MRSA has an altered PBP. Okay, that's a. I'm trying to remember where she mentions PBP. It's like an enzyme, honestly. I can't remember where it's at. But anyway, it's an enzyme that's used. So anyway, MRSA has an altered PBP, so it's like a target by penicillin binding protein. There we go. It has an altered penicillin binding protein, so therefore it's able to have a specific resistance. Okay, so it's like different resistance than these other ones that they kind of mentioned. It has an altered penicillin binding protein. Okay. So therefore, it gives you inherent resistance except to ceftaroline. I guess that's how you say it. Ceftaroline. So maybe no ceftaroline. Um, it's not resistant to that. Okay. So make sure you know that. And also, of course, just regular old vanc. You want to always give. I mean, yeah, vanc. You want to give MRSA. MRSA. You want to give vanc. My bad. All right. Intracellular bacteria are generally resistant as well. So that's just something else to note. Now, the reason I have the 2 stars here is the thing I was talking about. I think she said, like we literally talked to like Stacy and I talked to her in the hallway one day, and she was, and this was like this year, and she was like, "Yeah, I give that same question every year, and people get it wrong all the time." I think it was something to do with this, the whole garage house thing. Maybe it's the target of lactamase specifically. I'm sure she went into way more detail than what I said here. But yeah, so I know it was something to do with the lactamase, maybe like that bond that it messes with here. Um, but yeah, make sure you know lactamase associated with penicillin and maybe like what that site is. But she did say it was important. Beta lactamase inhibitor. So this is something that you would give along with a beta lactam, basically to make it like stronger or get past that beta lactamase that these bacteria will have. So anyway, clavolunate or clavulanic acid. That's a very common one that you put along with amoxicillin, and that's augmentin, which I'm sure you guys have way more. You probably remember that name way more than you do amoxicillin clavulanic acid. Yeah. And then sulbactam and tazobactam. Basically, what she wants you to do on this is just know that it's a beta lactamase inhibitor. That's kind of what she wants you to know. And that she might give you an example of the case like a bacteria gets, exhibits beta lactamase, like it has that, or something that leads you that direction. And then it's like, what can you add to, like, what drug do you add, or maybe what the mechanism of that drug is that you add, stuff like that. And then this talks a little bit more about specifically amoxicillin clavulinate. Um, I don't think there's really. Yeah, I guess that's just because that's what you mix along with clavulinate. And then beta lactam adverse effects. So seizures is a common one because it's kind of like it can be sort of serving a GABA antagonist type role in terms of its side effects. The one, yeah, I think it's spelled like that. Imipenem is the one that's like super common with seizures. So if they mention a seizure at all on that test, and it's a situation where you'd use a beta lactam, imipenem is the one you want to think of. And I think she honestly had a question like that, so that's why I have 2 stars on that. It's a very common one that is associated with seizures. Most are clearly renal. Ceftriaxone is the only one that's like not really renal side effect oriented. Um, and then ceftriaxone, however, it has its own separate one, and I think she may even had a question on that too. Honestly, I know she did somewhere, maybe not on in this class, but I think she had it somewhere else maybe. But it can displace bilirubin and neonates. Okay, so therefore you do not give it to neonates. All right, so penicillins. So you got penicillin G, penicillin V. Okay, they're used in strep and drug of choice for syphilis. Okay, that'll come back to you in repro. Okay, so that's where you'll hear that back once again with the syphilis drug of choice. And then once again, it even mentions it down here once again. So treponema pallidum, of course, that is syphilis. So effective versus T. pallidum that pregnant patients with penicillin allergy undergo desensitization protocol. That's crazy. But yeah, so definitely no penicillin G, penicillin V, and syphilis and strep. Um, Aminopenicillins, so it's ampicillin, amoxicillin. Um, Honestly, just know the red on this slide. I don't want to read like every single thing, but yeah. So there's another red on this slide. I don't really know why I underlined this. I don't think we had to really know that. And I think I came up with like my own, tried to anyway, my own acronym for these. For Neisseria, Escherichia, Haemophilus, and Iraq, all of those. Hheenlk. I think I tried to make it into a word, but of course that's not a real word. But yeah. I did add this down here for this slide. So oxacillin, nafcillin, cloxacillin, methicillin. There's a little saying that she always says: ox, clox, and naf are anti-staph. She said that like multiple times. So maybe it'd be like a first order question on this test, and I just don't remember it. But I kind of doubt that. But maybe. So yeah, of course, since they're anti-staph, they of course help with staph infection. Anti-pseudomonal penicillins, tisarcillin and piperacillin. Um, and I even kind of so what I underlined in here were things that I thought like stood out a little more. I don't think she honestly asked about them, but it was like my way of trying to differentiate between them all. The way I honestly worked through this was that I ended up writing things down and like on this one piece of paper, and I would just study that piece of paper over and over again. That's how I did it on this exam. This one's probably one of the more difficult ones just because there's a lot of them. Um, this one and the cancer one. That one's kind of hard too. And also, if you guys have access to that Anki deck that we had, I think Gunner probably posted it or something. But anyway, those are a lifesaver on a lot of those Pharm exams. Um, they're very good, at least the ones on Weaver anyway, because like I said, she pretty much sticks to red text anyway. So I would look into those if you guys haven't already. That would probably help you out quite a bit. They super helped me out with like cancer drugs. That was like super insanely good. So I would highly recommend. Then resistance to penicillins. So it talks about like how bacteria resist penicillin. Pretty straightforward slide. I don't honestly remember anything right off the bat. I know MRSA's mentioned once again, so maybe that. Now this was important to know, I think, and she brings it up in an example at the end of this slideshow. Um, is that cephalosporins they cover pretty similar, like kind of similar stuff to penicillins, but they're not active against all of lame. So lame is like the little mnemonic for what it doesn't cover. So that's listeria, and then the atypicals. So you got mycoplasma and you got chlamydia. It doesn't cover those. It doesn't cover MRSA and it doesn't cover enterococci. This one I left in here just because I thought it was like a good reference slide, and honestly, like I feel like I would have pretty good use of this now. It's a very good reference slide. Because every now and then you're like, man, what did that third generation do? Like I remember, like ciftriaxone or whatever. I remember what generation it's in, but I don't remember exactly what else it covers. So this would be a nice little reference slide. Now this is where it breaks it down into these mnemonics. Now these are super important to know. Okay, so you can either use the one she gives you, okay, or you can make up your own. But the ones I found like super helpful was like the peck things here. So peck, henpeck, those are like super helpful. Um, at least to me. So that's what I found super helpful on these slides. But anyway, first gen cephalexin, cefalozin, and gram positive plus PECK or PEC. So that's Proteus, E. coli, and Klebsiella. And then second gen, notice she has the mnemonic over here, and that gives you most of them. I think I added like maybe one more in there just to finish off the list or something. But I can't remember. Oh, maybe this fox tits. I don't know. I think I tried to come up with something else, to come up with that because fox, yes, cefotetan and cefoxitin may sometimes cover bacteroides for gallons. So that's something else. I just tried to like come up with something else, like desperately. But yeah, so basically use the hint packs and the packs. That's super helpful. And the mnemonics I actually ended up remembering too. And then Septinaire, list all these again. And notice I put it down here for you that it has like hen and pneumococci. So that's the first time that it's mentioned pneumococci. And then notice that it mentions ceftriaxone, cefotaxime specifically for that. And then down here, ceftazidime for Pseudomonas. That's a very common one that they mention with Pseudomonas quite a bit. I would also remember, of course, those anti-pseudomonals that we talked about back a while ago. So piperacillin, tisarcillin, I think that was those. And then cefepime, okay. So this also includes Pseudomonas, but it's much more broad spectrum. And then you have ceftaroline, I guess is how you say that. And that's basically like a ceftriaxone that covers MRSA. Okay, so make sure you just know what each of the generations mean, and everything in red. Super important to know. Know the pegs, henpecs, and the little mnemonics. They'll help you out. Carapinums, they're like the huge guns. Okay, you barely ever use them, honestly, because most of the time you're gonna kill whatever else, whatever's going on with something else. Carapinums is like basically if you're like, close to your last leg, and it's like, man, we need to just like eradicate everything. That's what these kind of drugs are. And notice aminopinum, that's the one we talked about earlier with the seizure activity. I think it even mentions it once more. So I put the star right there for you. And it talks about like specific carmapinums. I think it was also important to know like ESBL gram negatives specifically, maybe. Notice that it covers Pseudomonas as well. Cilastatin is added to imipenem to prevent deactivation by dipeptidase in renal brush borders. That's something else that kind of just stands out to me that she might like form a question around. She likes to kind of do that every now and then too, like if it's kind of like a random fact that's in red. Then you have aztreonine. Okay, so that's safe even in severe beta-lactam allergies. Okay, so that's because it's not really a beta-lactam; it's a monobactam, so it's a little different structure. And then so profile. So what it covers is very similar to aminoglycosides. So aerobic gram negatives, and that includes Pseudomonas. All right. Then cell wall agents in special populations. She always likes to ask about pregnancy, or at least it always seems like it. So keep in mind that vancomycin is generally safe in pregnancy, and that beta lactams typically are. Also, notice again that she mentions the ceftriaxone toxicity once more. Like I said, they just sound so familiar, especially that ceftriaxone thing. So just keep that in mind. I kept these two examples in here, and I answered like the additional question that she had. So nephron and autotoxicity is like because the answer is vancomycin, but then she asks like what other adverse effects? Then it's like nephrotoxicity and autotoxicity, as well as red man syndrome. And then of course you have this one, and this one's also the answer is vancomycin, but it's more asking you. I think it's kind of like trying to discover if you understand lame, basically. So I put all of that down here, and also why it's not F because it's monotherapy. But yep, I think that's it, guys. So almost right on the money. So I'm gonna go ahead and I'm trying to save it.